Okay, hello everyone. Welcome to the Ecmm webinar on COVID-19 associated Aspergillosis, Immunology, Diagnosis and Treatment. Thanks so much for joining and for the big interest in this webinar. We are happy to announce that there are nearly 500 registries and we had to close the registration a little bit before we could even start the webinar. But the good news is the whole session will be recorded and all the slides, including the presentations, will be available starting tomorrow on the same link as you logged in now for the webinar. There will also be an email sent out to all registries. So yes, my name is Martin Hoenigl. I'm the current president of the Ecmm. I am currently working as a faculty at UCSD in San Diego and also in Austria, Medical University of Graz. And I'm happy to introduce my co-chair for this webinar, which is Oliver Cornelli. Oliver, I hand over the microphone to you.
Thank you very much, Martin. Oliver Cornelli from the University of Cologne in Germany, where I work as infectious diseases and medical mycologist. And welcome. It should be a welcome to all of you, but without further ado, because we have a lot of highly interesting, really absolutely up-to-date talks, I'd like to hand over and call the first speaker. And let me introduce Dr. Carol Garcia-Vidal to you. She's infectious diseases consultant at the hospital and clinics in IDIM BAPS, Barcelona, Spain. Carol, please.
So thank you very much for your invitation. I'm so happy to be here with you today, and I'm going to talk about a very interesting topic, that is immunology on COVID-19 associated Aspergillosis. The organizers tell me that I have more or less 7 minutes, so I'm going to try to be very brief. But let me start from the beginning. No? And the beginning is that when an invasive Aspergillosis always starts with the same way, no? And this way is the inhalation of the spores from the airborne. Depending on the size of these spores, the possibility that these spores arrive deep inside of the respiratory tract is higher, and probably this is one of the most important reasons that more infections are caused by Aspergillus fumigatus. When Aspergillus fumigatus spores arrive here to the alveoli, there are two cells that are very important in the host response against this infection. And these two cells are macrophages, are dendritic cells. Let me start talking about the role of the macrophage. This is very important because when we have a macrophage dysfunction, here is where the spore can germinate and produce IFI that, as you perfectly know, is the invasive form of Aspergillosis. Much viral infections produce macrophage dysfunction. In fact, it has been very proved that in influenza infection, the function of macrophages is very poor. And we all know that this is probably one of the most important factors relating the pathogenesis of influenza and invasive Aspergillosis. In my country, we know that probably between 20 or 30% of patients with severe influenza who requires mechanical ventilation has associated invasive or complicating invasive Aspergillosis. So I have to recognize that when COVID pandemic starts in my country, I was really expecting about what would happen with this patient. This slide comes from Dr. Karen Mar, and I would like to appreciate her help. But you can see here in this slide that really the incidence of COVID-19 associated pulmonary aspergillosis has been very different depending on the country that reports this data. I can tell you that in my country, especially my hospital, we were really looking for this complication. And from the beginning, all the patients who need mechanical ventilation were submitted to galactomyn in serum, and when we take an invasive respiratory tract culture, we culture for fungal infection. But probably a little bit surprising for me, the incidence of COVID-19 invasive aspergillosis was relatively low. We had in the first month of the year, we had more than 2,000 patients admitted with COVID in my hospital. From them, close to 200 were admitted in ICU and required mechanical ventilation. And only 7% of these patients, only is a relative word, were complicated with invasive aspergillosis. And if we look the overall cohort of patients with COVID, only 0.6% of all hospitalized patients with COVID had complicating aspergillosis. So one of my questions, or one of the questions in my head that has been rolling during these years, during these months, has been trying to explain this one. And probably the pathogenesis or the immunological disturbance associated with COVID are quite different to the immunological disturbance caused by influenza. In fact, one of the most important differences is that COVID has intrinsically, and this is one of the bases of the most severe patients, they have a macrophage hyperfunction. So I'm not sure if this hyperfunction has worked in any way trying to protect these patients. When we say these patients have macrophage hyperfunction, really we don't have, we have no idea if this hyperfunction means good function or hyperfunction but with dysfunction. But there are questions that are unsolved right now. Let me jump to the other important cell, because we have only 7 minutes, no, that are dendritic cells. And here we have to relate this antigen presentation cell with the receptors that recognize the spores and also they find. And probably the most important in the response against invasive against Aspergillus are Dectin-1, PTX3, that is a soluble receptor, and toll-like receptors. When the fungi interact with these receptors, these cells produce an interleukin response that is that have the role to modulate T cells, and depending on how it works, we have one response mediated more by Th1 or Th2, and this has a very important impact in the outcome of patients with invasive aspergillosis. But what happens is, in a big picture, that we activate the immune system, and if in that moment we have a patient and we cut the lung, we will see something similar than this. That is that we can see we can see immune cell systems and also some spores. And here this work is what is making feel worse to our patients. In our mind, this picture is the definition of chronic necrotizing aspergillosis. So many of these patterns really are affected by COVID, but our information, real information about how these patterns are affected is yet not clear. Let me recommend this review that has been published a few days ago. They really explain on the hypothesis about some of these steps that are disrupted in COVID infection. No? They talk about the role of danger-associated molecular patterns that interact with or that make that the activation of toll-like receptors is in a different, I explained that the activation of toll-like receptors are in a different way. So for sure, this has a role in a changing response against invasive aspergillosis, and probably a better knowledge about the role or the balance or imbalance between interleukin-6, interleukin-1, and not only these cytokines, also the inhibitor treatments that we have been using for treat patients with COVID in the role of this imbalance in our immune system may explain some of the difference in the incidence and probably in the clinical forms of invasive aspergillosis in COVID patients. I think 7 minutes is a very short time, so I want to conclude very fast with these 3 points that we have many unsolved questions, we have few answers. So we have too much work to do, and I'm very happy with the team in this webinar because I'm sure that together we can do a huge work. So I'm open for questions, and if you want, I'm going to stop to share my screen.
Thanks so much, Carol, for this excellent presentation. As you emphasized, we have basically, we have really, a lot of program for these 19 minutes. So thanks so much for also kind of like keeping in time. And, I'm sure you're happy to kind of like answer additional questions that may come in direction, and, everybody is welcome, of course, to ask Carol. Before we start with the questions, basically, and there have already been some, I just want to introduce also some housekeeping issues. So all the audience who is watching this via the webinar is invited basically to ask questions via this webinar app. And basically we will then, Oliver and I, as the chairs, will then basically, ask the questions, forward the questions to the speakers. A second very important point, which I should have done in the beginning, I think it's very important to emphasize our gratitude and also our big thank you to everyone who made this webinar possible. And there's lots of organization behind it, of course, and a big thank you for an unrestricted educational grant to the ECMM from Diagnostics, who really helped to make this happen, and of course also to everyone from Congress Care who really helped us to make this in a good technical way feasible. So with that, I want to hand over to my co-chair, Oliver Corneli, for the first question.
And I managed to escape the sun for the moment because I couldn't see anything here a moment ago. So, but with the questions, actually, the first question that we received from the audience, the question is whether we try to sort them to the individual talks, because there is an epidemiology question. I would keep it for John later on. There is a diagnostic question, and now they are popping in. That's cool. Oh, here's a nice one. And Carol, have you seen a higher incidence of CAPA in patients who have received immune suppressive treatments? Dexamethasone or tocilizumab are the two examples here. Do you feel comfortable with taking that one?
Okay, thank you for this question. 80% of patients who have CAPA in my hospital were patients with chronic lung disease with more than 10 days with mechanical ventilation, and all of them with a high doses of corticosteroid. In fact, the use of tocilizumab and anakinra was a protective factor for fungal infection, not because the immunologic effect that these drugs has, if not because when we use these drugs, the patients do not arrive to the ICU. We use tocilizumab in a very early COVID stage. So most of these patients were protected to ICU admission and intubate. But lung disease, length of mechanical ventilation and high doses of corticoids, I think has been. This is a very different picture from influenza patients. I have seen very young people without comorbid disease in the first days of ICU admission with co-infection, influenza, and Aspergillus. But in my experience, the picture has been quite different. I don't know if you have seen the same or not.
There's another one for you, and I don't know whether it's possible to give a short answer to it, but I'll just read it. An increase of overactive, so to say, neutrophils is associated with severe COVID-19 and with reduced patient outcome. How would you say that fits in with the macrophage findings that you shared with us?
Well, this is only one hypothesis that I have been, that it has been in my mind. It's very difficult for me to explain why I have seen many intubate patients and low incidence of Aspergillus. And one of the points that I think is that maybe the hyperactivation of macrophages may help in this way, but I don't know. It's only an hypothesis.
Yeah, but that is what we have a lot with Corona. So it's new, and that is why we are all here to share not only facts, but what we think where the field is moving and what we might see tomorrow. So thank you very much. I think I have to hand back to Martin, who would introduce the second speaker. Thank you very much, Carol, for covering immunology.
Now it's my pleasure to introduce Professor Paul Verweij, the head of the medical mycology unit at Radboud in Nijmegen, the Netherlands. Of course, you know, a worldwide leader in the field of influenza-associated aspergillosis and also, you know, COVID-associated aspergillosis. I'm happy that Paul was willing to give the talk about definitions of this new disease we are seeing. So, Paul, the mic is yours.
Hello, everybody. Thank you, Martin. I have a couple of slides on definitions of COVID-associated pulmonary aspergillosis. Next slide, thank you. So first question is, of course, why do we need definitions? Well, that is, of course, clear because a lot of studies are ongoing at this time in COVID-19 patients. We need to be able to classify the patients, also for surveillance and for registries. And of course, we would like to be able to compare studies. So it's important to have definitions. And then the next question is, of course, can we use existing definitions of invasive fungal infections or invasive pulmonary aspergillosis? And if you look at the definitions which are available, we have the new EORTC, MSG ERC definitions, which were published in December last year. We have the Aspergillus ICU algorithm published a number of years ago by Blott and colleagues. And recently, an expert group proposed definitions for influenza-associated pulmonary aspergillosis. So in general, these definitions, they look at host factors, they look at clinical factors, including radiology, and also they look at mycological evidence. So when we consider the EORTC, MSG, ERC definitions, there are a lot of host factors which are listed, and many of these host factors are related to the immunocompromised state of the patient. Also, if you look at the clinical factors, there are some specific lesions like the halo sign, the air crescent sign, which have to be present to be able to classify a patient. And the mycology very much depends on Galactomyn detection, and also Aspergillus PCR was included. So in general, it's been difficult to classify these patients because patients with COVID who develop invasive aspergillosis often don't have the host factors or don't have the clinical factors. Also, ICU was excluded from these EORTC definitions, and many patients with CAPA are in the ICU. So it looks like these definitions are not very useful to classify patients with CAPA. So the second definitions are those by Blott et al., which were specifically designed for ICU. And those definitions, they start with an entry criterion based on a positive culture of a lower respiratory tract specimen. It also includes clinical factors and symptoms, and also abnormal imaging, although it's not clearly specified what images should be present. But again, there's a list of host factors which need to be present, mainly aimed at immune suppressed state of the host. So also these definitions are limited by the fact that you need host factors, and also that they only include culture and not antigen detection. So recently, experts proposed a definition for influenza-associated pulmonary aspergillosis. And this definition does not include host factors. It actually includes an entry criterion, and that is influenza-like illness with a positive PCR or antigen for influenza, and they have to be temporary related. And if somebody meets this criterion, then you have proven or probable disease, and there's a distinction made between Aspergillus tracheal bronchitis, which is frequently found in influenza-associated aspergillosis, and those without tracheal bronchitis. And if you then look at the probable criteria, much is based on positive antigen in BEL or serum or positive culture, and that might be useful, as the authors also indicated, also to classify patients with CAPA. And the authors, the experts said, well, the proposed case definition might be useful to classify CAPA patients, but this was, of course, only in the early days that we were just starting to see patients with CAPA. So a couple of days ago, a study was published from Italy where they systematically investigated 108 patients with COVID-19 in the ICU. And the interesting part is that they did systematic bronchoscopy in these patients on day 0 and day 7. And they used both these two recent classifications, the one of Blot et al. And also the influenza case definition, to classify their patients with CAPA. And you can see that they could classify 19 patients according to the Aspergillus ICU case definition and 30 patients according to the IAPA case definition. What they also saw is that there was a significant difference in survival using both case definitions, which I think was very interesting. But most patients could be classified according to this influenza case definition. But it's clear, as indicated by the previous speaker, that CAPA is different than influenza-associated pulmonary aspergillosis, and there are some important issues. And the first one is that if you have influenza and you find evidence for Aspergillus, the probability that the patient has invasive aspergillosis is quite high, and the number of colonized patients is low. But in CAPA, I think the presentation is much more heterogeneous, and more patients will be colonized and have positive culture, for instance, but don't have invasive disease. That was recently shown in a study where they had histopathological analysis of patients who would classify as probable CAPA cases, but there was no evidence for invasive aspergillosis. The other issue is that if you look at influenza-associated pulmonary aspergillosis, about 65% of patients will have a positive serum galactomyn. But in CAPA, it seems to be much lower, and the most recent study indicated a sensitivity of only 6%. And that is, of course, a problem, because then a lot of weight is given to the BAL galactomyn or culture. And also, of course, there's a reluctance to perform bronchoscopy in these patients. And then the question is, should we add other materials like tracheal aspirates or sputum to the case definition? So given these limitations, taking these into account, there is a new consensus statement on its way. And a number of organizations are involved in this, including Ecmm, and it is led by Philip Köhler. And I think it's important that we have a good case definition which we can use. So that's it. I'm happy to take any questions. Thank you very much.
Thank you so much, Paul, for this excellent presentation and great overview. There is a number of questions, and considering the time restraints we have, we unfortunately can only ask a few of those. I think I will start off with something that's maybe not 100% only related to your call, but to your talk. But you will be an excellent expert to answer this, namely about why CAPA seems less frequent in the USA and Canada than in Europe. Does this only have to do maybe with diagnostics or a delay that may occur because of the wave? Or what are your thoughts about this, Paul?
I think that's a really good question and also very difficult to answer. If we look at influenza-associated pulmonary aspergillosis, it's clear that there are significant differences in the epidemiology and in frequency of cases. And we don't understand why, because we think that people will be exposed to Aspergillus maybe in a similar manner. But it's clear that there are differences, and it could be that there are less diagnostics performed. But I think now many people are aware of the possibility of aspergillosis occurring in patients with severe viral pneumonia. So I think that's an important question that we don't actually know the answer to yet.
Thank you. So Oliver did another question. Do you have another question that you think is kind of like, we have so many questions, so it's hard to kind of like filter the most important ones, the most relevant ones?
We can take the one in the middle. I mean, it's whether it's only aspergillosis and what about the other fungi? So do you see PCP, for example, pneumocystis, with all the steroids we are discussing? And I would, that's a question from coming in, but I would actually add, how about candidemia, invasive candidiasis?
So I did a recent search in literature and did not find any PCP cases, but that's always difficult because every day new evidence is emerging. In my experience, mainly we see invasive aspergillosis in these patients, but I think if they are prone to develop aspergillosis, it's likely that they might also be at risk for other fungal infections.
And I have a final one, which I think is kind of like very important, and that's basically, first thanking you for a great presentation, but then asking specifically how you would interpret BAL galactomyn above 1 without any other risk factors than COVID and ICU admission. And I think you answered the part, but I think it's just important to re-emphasize how you would interpret this specific.
Yeah, so BAL galactomyn 1 is of course at the cutoff of what we consider positive. So I think it's always important to consider other evidence in these patients. So are they deteriorating or not in the ICU? Are they receiving other immunosuppressive agents like corticosteroids? Is the serum galactomyn negative or positive? It's probably negative, but I think it's always important to see if there are other evidence which could help decide if this patient really needs antifungal treatment or not.
Thank you so much, Paul. Excellent. Thank you. So thanks for this great talk. I'm happy to introduce now our next speaker, John Salmanton-Garcia. He is a PhD student from the University Hospital of Cologne in Germany. And he has done a lot of work already on the epidemiology of CAPA, and he will talk about epidemiology in Europe and beyond.
Thank you very much, Martin, for that presentation, also for inviting me as a speaker in this webinar. As Martin said, I will talk about epidemiology in Europe and beyond of CAPA. First, I would like to start saying that I checked together with my colleague Rosanne Sprute for all the patients or all the cases that have been reported in the literature in order to determine whether they had a colonization or a real infection. And actually, we followed the 3 definitions mentioned just now by Paul. We classified the patients according to EORTC-MSE criteria. If this was not possible, we followed the blood algorithm. And finally, we used the Verweij consensus definition. With regards to incidence, a question that has already arisen, I have seen 3 different types of incidences with regards to the number of CAPA, with regards to the whole sample of COVID-19 patients, ICU patients, and mechanical ventilation. And actually, there is a wide variety in these numbers. For COVID-19 patients, we have incidences between 0.7 to 7.7%. In ICU patients between 2.5 to 39.1%, and in the case of patients with mechanical ventilation, the range varies between 3.2 to 29.6%. If we have a look on the prevalence and on the cases reported in the literature, here we have a map of Europe, and we can see in blue color the countries that have reported cases to in the literature, 71, or in Fungiscope registry for an incoming publication that will come soon. This makes a total of 124 cases from Europe. And if we go beyond Europe, we can see how in the literature, 9 cases have been reported from Pakistan in the literature. 7 cases from Mexico have been included in Fungiscope registry. 1 case has been reported from the literature from Australia, and another one from Brazil. And if we look to the data from China, I cannot really provide a real number because all the patients have been provided in case series, and I didn't manage to get feedback. But we could say, or we could estimate, more than 68 patients from China. And with regards to the baseline characteristics of the CAPA patients, I observed how most of the patients were male, 3 out of 4, all of them with ICU admission, and between these ICU admissions, all of them with ARDS, and almost everyone, 90%, with mechanical ventilation. With regards to baseline conditions, we have 60% of the patients with chronic cardiovascular disease, around 50% of the patients with previous corticosteroid administration and diabetes mellitus each. And then, quite interestingly, chronic pulmonary disease has been reported only in around 50% of the patients. With regards to the diagnostic procedures, 90% of the patients presented abnormal imaging procedures, either in CT scan or in X-ray. There was not really a big difference between one test or the other. Of course, mycological evidences from every patient, mainly from culture, in around 90% of the patients, especially half of them, more than half of them actually, from tracheal aspirate. Galactomyn and positive test was observed in around 40% of the patients, even distribution between serum samples and BAL samples, and histology, positive histology was observed only in around 15% of the patients. Now we have in this pie the distribution of the pathogens, and we can see how the main pathogen was, of course, Aspergillus fumigatus in almost 75% of the patients. And here's something interesting. Azole-resistant Aspergillus fumigatus infections were observed in 3 patients. Aspergillus flavus afterwards in 7 patients, Aspergillus niger in 3, Aspergillus tubingensis and Aspergillus penicilloides in 1 patient each, and no species level identification was performed in 2 patients. With regards to the antifungal therapy, most of them, almost 60% of the patients received triazoles, mainly voriconazole and also some of them isavuconazole. Amphotericin was administered in around 15% of the patients, echinocandins in 10, and quite interesting this, no treatment was administered in 30% of the patients. Almost 1 patient out of 3 received no treatment for the aspergillosis, even if they were proven probable or putative aspergillosis. And finally, last but not least, outcome in these patients, there was an overall mortality of 50%, but it's interesting to say that more than 90% of these patients died before day 42 after aspergillosis diagnosis. With regards to the reasons for the mortality, more than half of the patients, there was either no reason or not reported reason, or the reason for the mortality was not reported, was not related neither to COVID-19 nor CAPA. CAPA was reported as the main reason of the death in around 10% of the patients that died, An autopsy was performed only in 2 patients. Thank you very much, and let's go with the questions.
Thank you so much, John. Thank you so much for the great presentation. And also thanks for staying in time. So we got a number of questions. One specifically over to you. This is about the incidence case. I think this has been asked before, but I think it sounds better for you. So,
I can't really hear you, Martin.
Yep.
Okay. Can you hear me now better?
Yes, much better.
Okay. I was probably having my hand on my microphone. So the question was basically about the incidence, and we heard before, that it was 7% from Spain. But what are your thoughts, why there reports are even within Europe so different? We have other places where it's 90% or even 36%, and there's just very different rates. And another question that comes into this as well from Esther Segal is basically, if you think that climate would play a role in the frequency.
Well, I mean, actually, before starting the talk, I didn't have any data from Spain because no reports have been reported so far, but there will come. I mean, I know from Iker Falque Romero from La Paz and also from Gregorio Marañón Hospital in Madrid. About the huge difference, actually, I don't really say why, because, I mean, one could think that more cases could be reported from Spain due to the highest burden of the pandemic in there, compared to, for example, in Germany. But well, actually, the data say the contrary. I mean, Carol said that they had 7% of incidence, and here from our hospital we reported higher incidence. Maybe it might be related to the main incidence level of aspergillosis even without COVID-19. And yeah, but I mean, definitely that would need an analysis, and actually I think it's quite soon yet, because yeah, I mean, there has to be a report of those cases, and until those data are not public, we cannot really say it's because of one reason or the other.
Thanks so much. Great question, great answer. I think there's a lot of questions. One question specifically asked also, what we will do with all these questions that kind of can't be answered during this webinar because of our limited time. And, I think, we will see technically feasible basically to, go back to the questions later on. If it's feasible, definitely, I think, the faculty will try to go back and answer them after the webinar during the next days. So that's something we will look into and see if this will work. Oliver, another question that before we move on.
John,
yes.
Thank you very much for doing this, because I know that you're kind of stressed at the moment. John has his PhD defense on Tuesday, so mark your calendar if you want to congratulate, because if he delivers a talk like he did today, then all will be good. I'd like to ask one question, John, and that goes in the direction of the geography that you shared. One is no cases from Africa. I don't know whether Martin brought this up already, because I was sorting things here, but no cases reported from Africa. What do you think? You can only speculate.
Well, from my experience working this already 3.5 years in Fungiscope, the report of fungal infections from Africa in general, it's quite complicated and it's quite low, except for the endemic mycosis. And also, after talking to some people in Africa, the main problem is the diagnosis. They don't have, in certain places, they don't have access to diagnostic tools. So then if we start with that problem, they cannot really diagnose, so they cannot really report. And with regards to one question was about the incidence in the States and Canada. I know there have been cases in both countries, but yeah, I guess that probably due to time restrictions, or also because the pandemic is going there later, they didn't have time to report. But certainly, I'm quite sure there will be reports from there.
Yeah, and for North America, there is a report that just came out. You know that we shared that. Okay, well, again, thank you very much. We could do that the whole evening or whatever time zone you audience are in, but we need to move on. And Martin, do you want to introduce?
Definitely, I would be happy to.
Okay, I thought
Thanks for handing over. Yeah, so next talk will be again from Nijmegen, and it's my pleasure to introduce Dr. Elko Meijer, who will talk about azole resistance and its relevance for CAPA. He's a resident from the Medical Mycology department in Nijmegen. So the mic is yours.
All right, thank you very much for the introduction. Can you hear me? Is this working?
Yes.
All right, perfect. I was asked to give a presentation on azole resistance in CAPA, and indeed I work in Nijmegen, the Netherlands as well. All right, perfect, this works. So some content, I'll quickly go through some background and then discuss some azole resistance worldwide and then specifically in CAPA, and discuss the 3 case reports that are published so far by myself, by Mohammed and Galveston-Pereira et al. From the Netherlands, Ireland, and France. So a bit has been discussed already, but Aspergillus fumigatus, the species, is most frequently encountered worldwide, and you can find some Aspergillus flavus in some sub or tropical climates as well. And Aspergillus tertius, it can also be found in some specific locations, which is relevant because of its intrinsic F and B resistance, but it's infrequent elsewhere. But most importantly, the local resistance epidemiology dominates the choice of primary treatment. So that's really something to keep in mind. As colleagues have shown, that 25% increased mortality can be seen when invasive disease is caused by an azole-resistant strain. So it's very much clinically relevant. So if we look at the data that has been published in 2019 on azole resistance worldwide, the resistance percentages, they differ between mostly unknown, but in countries where data is available, somewhere between 1 and 10% is what is most common, with some exceptions in, for example, Netherlands, but also Britain and elsewhere. And if you look at azole resistance in CAPA, you have to keep in mind there are CYP51 mediated resistance mechanisms and the non-CYP51A resistance mechanisms, where CYP51A mediated is usually environmental, has an environmental source, and the non-CYP51A, so 51B or efflux pumps or SNPs or the others, are usually due to long-term azole use in, for example, CPA or cystic fibrosis or patient with lung cavities, etc. From an environmental source, the most common resistance mechanism is the TR34 L98H resistance mechanism. Has been often described, and it's often associated with itoconazole and post-conazole resistance, and variable for the conazole and isobutanol susceptibility, and often resulting in panazole resistance. When you look at COVID-19 patients, these are patients that are often immunocompetent, that have no azole treatment history, so therefore you can expect to find environmental resistance mechanisms, which is important for diagnostics. So the recent reported cases from myself and colleagues published recently in June, and from Ireland, also in June 26 for medical mycology, and then from France, there's one also recently published in July 2nd. I'll go through those, or just give a short summary on them. So if you look at the cases, they're all aged between 56 74. 2 out of 3 cases report diabetes and obesity. They're all immunocompetent, at least they were before admission. They all had COVID symptoms, cough, dyspnea, malaise, fever, and they had no azole treatment history. They were admitted to the ICU for ARDS, all of them, and all 3 cases report the tier 34 LNA8H, the leucine to histidine amino acid change in combination with the 10 repeat gene amplification. And if you look at the BALF, the bronchial alveolar lavage, or tracheal aspirate Galactomyn, then 2 out of 2, so only 2 out of 3 publications report this, and from the 2 that actually reported it, they were strongly positive, and 1 not applicable, obviously, because it wasn't tested. If you look at serum Galactomyn, only 1 out of 3 cases report a positive result, which is consistent with what Paul just mentioned. And also in recent case series, the sensitivity is seems to be really low in COVID patients, or at least CAPA patients. And serum BDG, in these reports, 2 out of 3 were positive, and 1 of them was very highly positive. ICU admission to the diagnosis was, and diagnosis being CAPA, was really short, which I like to emphasize, only 3 to 7 days in these cases, which is interesting. And then COVID symptom onset to CAPA diagnosis was 14 to 22 days. So just to conclude, azole resistance data with CAPA and actually worldwide, they're still limited. Environmental strains are found in CAPA patients, which is to be expected. And primary therapy is based on epidemiological data, so surveillance in this is key. Thank you.
Thank you so much for the excellent presentation, Elko. So one quick question basically that came in, and this is, of course, not only, Aspergillus can be azole resistant, but also other molds. So, and we know that there is a report about Fusarium, a case of Fusariosis in CAPA as well, published in CMI. So the question was, if you are aware or you've seen basically other mold infections, that, potentially are resistant to azoles in COVID-19 patients.
So we have not seen them. I've read the report on Fusarium, but I haven't seen many others. So for now, it's usually Aspergillus what we find.
Okay, I can just add for Graz. So we have seen a case of mucormycosis that will be published at some time. But yeah, everybody's busy.
There is a case mentioned of Fusariosis. It was in one of the questions, and there is another one on the new hybrid Aspergillus latus in COVID-19, whether anybody has seen that. For me, the answer is yeah, too early. We will see it later this year, I presume.
Yeah. Okay, great. So I think let's move on. Kind of like, we are a little bit behind time, definitely not because of you, Elko. Thanks for the excellent presentation. But let's move on with the next talk, and we'll move over to diagnosis. And I'm happy to introduce Jean-Pierre Gangneux, who will give us kind of like a state-of-the-art overview, diagnosis of CAPA, how it's done. He's professor in medicine and specialized in mycology, tropical medicine, and environmental health at the Rennes Teaching Hospital at the Hospital of Rennes. University Hospital of Rennes. And thanks so much, Jean-Pierre, for joining, and looking forward to your talk.
Thank you, Martin. So the optimal diagnostic algorithm for CAPA is currently unknown. Yeah. And you all know that tracking the fungus is essential during invasive aspergillosis with conventional mycology and surrogate markers such as antigen detection or PCR. And when a chronic infection during chronic respiratory disease is suspected, then it's important to also look at the host response with antibody serology. The problem with ICU patients, and particularly patients co-infected with viruses such as influenza or SARS-CoV-2, present with unusual underlying conditions and combined risk factors, as we have seen. And the main unresolved question for CAPA are: what are the entry criteria? What are the test performances? And a panel of experts asked the question of the positive predictive value of culture isolation of Aspergillus, and also the performances of blood tests. And as we have heard with Paul, we need for an accurate case definition. First, looking for entry criteria. So, of course, there is a need for positive SARS-CoV-2 PCR associated to clinical deterioration and a CT chest imaging, even if we know that imaging lacks lack of sensitivity and specificity. Then, when possible, the bronchoscopy allows a tracheobronchial inspection, allows also bronchoalveolar sampling, but the problem is that it is an aerosol generating procedure. And the third entry criteria is the mycological evidence, but in this case, what samples and respiratory or blood samples and what techniques. So when analyzing the literature, we can see that half of the patients benefited from bronchoalveolar fluid. And it is also interesting to see that half of them benefited from tracheal aspiration. And this is interesting because tracheal aspiration are more easy to perform for monitoring during ARDS. For example, twice a week, it's more easier than BAL, and it is at lower risk for healthcare workers. And when we get these samples, then we can perform the direct examination, the culture, Galactomyn, but theoretically only for bronchoalveolar fluid, and PCR. Sputum are more anecdotal. If we try to look at the performances of the diagnosis on respiratory samples, first we have to keep in mind that we have only few patients per study, between 1 to 10. So we need more study to have a real photography of the performance of the diagnostic test. And it's better to talk on ranges rather than on precise values. If we look on the 3 reviews on CAPA patients, from 33 to 38 patients, but it is almost the same patients, we can see that culture is around 80% of sensitivity. Galactomyn is in respiratory samples near 60%. And it is quite surprising, but some reports report low sensitivity of qPCR, but this is not really what we have in routine. But in all cases, you can see that one mycological criteria was used to classify as probable CAPA. In our experience in REN, we had the same similar performance of culture, but we have a higher sensitivity of PCR than culture. Regarding test performances on blood samples, then it is very disappointed. And as previously mentioned, we have 1/3 of the patients that are positive for Galactomyn in blood. The level of positivity is higher for beta-D-glucan, but we know that in ICU patients, we can have a lack of specificity for beta-D-glucan. So I think we have to take care for this marker. And qPCR was not useful in the published cases. So we can see that there is a limited blood invasion. And however, we have to notice that a negative beta-D-glucan cannot rule out CAPA. Looking once again at our experience, we have similar results with 30% of positive patients with Galactomyn in blood and 30% for qPCR in blood. Regarding mycology, we also need for more knowledge about biodiversity. We know from Gaffey works on chronic pulmonary aspergillosis that Aspergillus fumigatus is the main Aspergillus species responsible in the northern countries, with more Aspergillus flavus in southern countries. And during CAPA, the first case reported from China was due to Aspergillus flavus, and we have seen in other published cases a wide majority of Aspergillus fumigatus, but as mentioned by Oliver, we have not enough data from South America or from Africa. So we need to try to isolate Aspergillus responsible for CAPA. And second, we also need to isolate them in order to know if they are resistant. I've just mentioned the first case here, but the previous speaker I've given more information on azole-resistant Aspergillus. So what are the key issues for the diagnosis? First, the monitoring of respiratory samples is essential, but there is a need for distinguishing co-infection from colonization. And I believe that we need some composite criteria. Mohamed and colleagues recently proposed to combine more than 2 mycological criteria among the following: galactomannan, isolation of Aspergillus, serum beta-D-glucan, or qPCR. And in our experience, we have shown that the cumulative number of positive samples is also important during the monitoring. One patient with only 1 isolate of Aspergillus in 1 sample is not is far different from a patient with all samples positive. And in case of chronic pulmonary diseases, then antibody serology may help in order to consider if the patient is with an invasive aspergillosis or chronic aspergillosis. The second point is that many hospitals have implemented a blood monitoring twice a week, similarly to neutropenic patients, but this is very disappointed. And there is a very limited relevance of antigen blood monitoring with a sensitivity that is very low. But we have so to keep in mind that galactomannan and beta-D-glucan are not exclusion tests, and we have in the literature numerous proven and probable cases with negative determination. Regarding antigen detection, then we have to look also for the interest of point-of-care tests, but Lewis White and Martin Hoenigl will talk on that. And the third point is that we need more studies with more patients in order to really evaluate on a prospective or consecutive study the relevance and the performance of the various tests. Thank you for your attention.
Thank you very much, Jean-Pierre. And I can't start my video, but you can hear me, which is more important than seeing me. And it's good that you just returned from vacation, because here's a long list of questions for you. And number 1 is beta-D-glucan. You had it in your talk and you were not a fan of it. Why?
So first, I have limited experience with beta-D-glucan, but the problem is that in ICU, we know that we have a high rate of false positivity. And during classical invasive aspergillosis, we usually use it as an exclusion criteria. So the predictive positive value of beta-D-glucan needs to be evaluated for me.
So you still would use it in a COVID patient with or without Aspergillus if you don't know what else is going on. So you might want to use it to diagnose other fungal infection. Yeah,
of course, glucan is important for pneumocystosis. So then there is no problem, but with a higher level of antigen.
Yeah. Okay, that was the easy one. So here's the next. What is the cutoff of galactomannan in tracheal aspirate?
So if we look at what the manufacturer says, we cannot use galactomannan in tracheal aspirates. It is only used for blood and for BAL. And in BAL, the cutoff is 1, and in blood, it's 0.5. But in tracheal aspirates, at this time, I don't know if we can really use it. It's not recommended by the manufacturer.
Okay. But how do we then diagnose without bronchoscopy? That's the next question, actually.
Yeah, so in this case, tracheal aspirates are important because we can have culture and we can also perform PCR on tracheal aspirates. So I think when bronchoscopy is not performed, then we have to combine some criteria such as culture of tracheal aspirates, qPCR, And of course, we can also do in parallel blood tests, but even if we know that their sensitivity is very low.
Yeah. Okay, so we have currently 410 people online joining us, and with that important information, I hand back to Martin.
Thanks so much, Oliver. So it's my pleasure to introduce the next speaker, Louis White. He is the principal clinical scientist in public health, Wales microbiology in Cardiff. And yeah, he is kind of like, has a lot of interesting data. He will talk here about point of care diagnosis, soon reality. He has also very new data about point of care diagnosis of COVID-associated aspergillosis. And I'm really looking forward to your talk, Louis.
Thank you, Martin. So there are my disclosures for those of you that are interested in those kind of things, not particularly me. So as Jean-Pierre has succinctly put it, the diagnostic options for mycological investigations are wide and quite varied. Obviously, we have our conventional approaches, microscopy and culture, and then our non-cultured approaches. Now, they all bring benefits and limitations alike. But the question is, can they be used as a point of care test? Now, if we go to Wikipedia for our definition of a point of care test, it is a medical diagnostic test at or near the point of care. And point of care is defined as the time and place of patient care. It would need to be rapid, simple to perform and to interpret, and cheap to perform. But I suppose cost comes down to sort of subjective analysis in relation to sort of what we're spending on treatment and also geographical variation. So if we apply that to our diagnostic options, I suppose one could actually say that microscopy is quite simple to perform, quite rapid, and could be done close to the patient. In that you took a BAL from the patient, you could prepare the slide and look at it in a microscope in close proximity to the patient. I would say that while the actual process itself is quite straightforward, the interpretation of the slide image is far from straightforward and would require a specialist personnel to interpret what was seen down this actual slide, down the microscope. So I think that rules it out. And really all we're left with is basically sort of the lateral flow devices, the lateral flow assays that could potentially offer us as a point of care test. So lateral flow devices are relatively cheap. I'll touch on that in a slide or so's time. They are simple, generally providing us results within 30 minutes. They're also quick. But in terms of the sort of the simplistic process, we will basically put either the neat specimen or the process specimen into this well you can see here, which is the OLM lateral flow device, the first sort of derivative of that. And basically you put the sample in there and it makes its way up the strip. And then you get 2 bands if it's positive and 1 band if it's negative. And so visual inspection is possible. You can do this by the eye, but I think the problem comes in is when you start to get down here where you've got strong positive, great, moderate positive, okay, you can see that, weak positive, this is where it becomes completely subjective. Now, while visual inspection is good, it only provides us with a qualitative result, which is difficult with antigen titers, because it's important to know the Galactomyn index when interpreting the significance of your positive results. But it does allow us to basically do away with the need for specialist equipment, which is very, very important when you come to resource-limited settings. And this has been demonstrated by the impact of the cryptococcal antigen lateral flow device, which has revolutionized the detection of cryptococcosis. And meta-analyses of the performance of the cryptococcal lateral flow device have provided exceptional sensitivity and specificity, whether you test serum or CSF. And it's close to being basically a perfect test. Now, in regards to Aspergillus lateral flow tests, the first was described in 2008 by Christopher Thornton, when the monoclonal antibody JF5, which basically targets a glycoprotein that's expressed only from actively growing hyphae of Aspergillus, basically, he then went on, not personally himself, other people went on to describe performance in bronchoalveolar lavage fluid and in blood, but primarily, obviously, serum more so than plasma. Now, in 2012, the Americans, under the sort of the supervision of Kieran Marr, described another monoclonal antibody, 476, and this was used to detect Galactomyn in urine specimens, initially from an animal model and a few case patients, but just recently in 2018, they've described performance of this urine Galactomyn test in 78 patients, 30 of which had proven probable aspergillosis, and provided decent sensitivity, but sort of very good specificity. To date, there's been no more publications describing this performance, so I won't mention this test any further. So at the moment, there are two commercially available Aspergillus lateral flow tests. We have the OLM Aspergillus lateral flow device and the IMI Aspergillus Galactomyn lateral flow assay. Both are CE marked, but I believe that the IMI assay at this moment is going through the process to gain FDA approval. The OLM assay uses the one monoclonal antibody, JF5, as previously described, while as the IMI assay uses two monoclonal antibodies. The MEA5 monoclonal binds to a similar GM epitope as the EBA2. The EBA2 monoclonal antibody is the one that is present in the Biorad Aspergillus antigen ELISA test. They also use an undisclosed novel monoclonal antibody. And what they've done here is when they redesigned their cryptococcal antigen test and made it into a lateral flow, they realized previously that they weren't picking up one of the serotypes of Cryptococcus. And so what they did is they introduced another monoclonal antibody to increase the sensitivity of the cryptococcal antigen and greatly improve its performance. So they followed the similar design rationale here and introduced a new novel monoclonal antibody with the idea of potentially enhancing sensitivity. Turnaround time for both tests is less than 1 hour, and both use a relatively small sample volume. Slightly less for the OLM assay, and even less if you're actually using direct sample, direct testing, i.e. you're taking your bronchoalveolar lavage and you're putting it direct onto the cassette. And in that process, you only need 70 microliters. Processing time is very, very short, i.e. hands-on time, less than 10 minutes for the OLM device, between 10 and 15 minutes for the IMI device. And that's because basically when you're processing bronchoalveolar lavages or serums with the IMI device, the initial denaturation, or rather the initial preparation of serum or BAL takes around 8 minutes at 120 degrees compared to 3 minutes here with the OLM device. At this moment in time, there is no evidence to suggest that we can do direct application of unprocessed specimens to the actual lateral flow device for the IMI assay. Both have visual readers. This little cube reader here, they both have visual readers available. And this limits subjectivity and also provides a quantitative result, which, as I've mentioned, is very, very important when it comes to interpreting the significance of your positive result. And this also helps in the situation where one person can see a band and the other person can't. This assay gives you an absolute figure. It does help. In terms of costs, both assays generally going to cost somewhere between 10 to 15 euros, dollars, pounds. They're not that different now by exchange rates. So they are relatively cheap. I must add that this doesn't take into account the cost for a startup assay, which would then also provide you with the actual cube reader. And generally, these are going to be in the price between somewhere between 1,000 to 2,000 euros. In terms of performance of the OLM assay when we're testing blood, again, this has started in 2018. Most of it, when we've come to blood testing, has been using the prototype. And there's little data on performance of the CE marked version of the test highlighted here when testing blood. Martin is going to touch on the performance of these assays, the CE marked assay testing BAL. So what we have found is the meta-analysis on these prototypes showed that sensitivity was around 70% and specificity was around 90% when testing serum. But what the meta-analysis did show was that performance was better when you tested sort of the more targeted specimens, such as bronchoalveolar lavage. And that's not surprising, given aspergillosis is primarily a respiratory disease. What we found in Cardiff, when we evaluated the performance of the OLM lateral flow device in combination with Aspergillus PCR and Galactomyn and ELISA, is that when it was combined with PCR, we had optimal performance. Sensitivity was 100% when we combined PCR with the lateral flow. So in other words, when both tests were consistently negative, we could exclude aspergillosis in the patient. When both tests were positive, it was 100% specific and so confirming disease. But we have to bear in mind this was primarily done on hematology patients and not on CAPA patients. We also need to take into account the impact of antifungal therapy on performance, particularly when testing blood. We already know that the OLM lateral flow device, the sensitivity is reduced when testing BAL fluid. This is a study from one of Martin's group. And you can see it's a significant reduction in sensitivity when the patient is on antifungal therapy. In relation to blood, there's an even more marked reduction in sensitivity, bearing in mind that this has come from an animal model from Tom Patterson's group. And what they found was on day 7, you can see that the sensitivity drops from around 90% to less than 20% in animals that have aspergillosis, and this is across their full repertoire of antifungal drugs. So what about the performance of the imilateral flow in blood? Data to date, this is some work we've just had published in JClin Micro recently in about the last month, and it describes the performance of the imilateral flow assay in blood from patients in the Cardiff setting, mainly hematology patients, 136 patients tested, of which we had 27 proven probable cases of invasive aspergillosis and 4 cases of probable invasive fungal disease. Now, this probable definition comes from the fact that they had radiology in keeping with aspergillosis, but they were Galactomyn and ELISA negative, but beta-D-glucan positive on multiple occasions. We also had one case of chronic aspergillosis where the patient had antibodies to Aspergillus and had sort of clinical keepings that were in keeping with a chronic condition, chronic respiratory condition. What we found was that the actual digital reader was critical for detecting weak positives that couldn't necessarily be picked up by the eye. We had good agreement with the Galactomyn and ELISA of around 90%, but the Galactomyn index generated by the lateral flow assay was significantly greater than that generated by the Galactomyn and ELISA. And that was irrespective of whether they were from cases or from controls. But the main thing was that the samples from controls, the 90th percentile was still below the 0.5 Galactomyn index cutoff. So we weren't generating a huge number of false positive results. When it came to the 4 cases of probable invasive fungal disease, it turned out these were actually indeed Galactomyn and ELISA false negative results. All 4 patients were positive using the IMI lateral flow assay. So when we look at actual performance using the well-accepted 0.5 threshold for positivity, you find that we had exceptional sensitivity and specificity. So much so that I actually doubted the results. If I hadn't seen the results myself as they came off after being tested, I wouldn't have believed them. But we do have to bear in mind that this was a retrospective case control study, and that if we go down the situation of a prospective study, the performance might change. If we reduce the threshold to 0.3, we generated 100% sensitivity. So Galactomyn and values less than 0.3 pretty much ruled out aspergillosis. And then conversely, if we use a threshold of 0.6, specificity was greater than, was 100%, confirming infection if you had Galactomyn and index values greater than 0.6. So this gives us a little bit of background about where we are at the current situation. But what about the use of lateral flow assays for the diagnosis of CAPA? This is a study that we've just at the moment finalizing in Cardiff, where we've looked at the imilateral flow assay, basically taking patients, taking samples that were part of our enhanced screening process for determining CAPA in critically ill COVID-19 patients. And the manuscript is currently available on the SSRN website as a preprint. From that study, we've looked at 19 patients with CAPA, defined using classifications that we feel are accurate. And what we had was 19 cases of CAPA and 4 cases of invasive pulmonary aspergillosis, where there was clinical suspicion that the patient had COVID-19 infection, but the patient remained PCR negative, and many of you will know that happens quite regularly. And we had 61 patients without any signs or symptoms of invasive pulmonary aspergillosis. We tested bronchoalveolar lavage or non-directed bronchial lavage, and the patients were tested prospectively by Galactomyn and Aspergillus PCR and retrospectively by the lateral flow assay. What we found was good a qualitative agreement, close to 90% between the lateral flow and galactomannan assay, and a CAPA statistic of 0.7, which represents excellent agreement. We also found that there was some significant correlation between the galactomannan index generated by the Biorad assay and that generated by the lateral flow, although I have seen better. But I think this sometimes represents some of the difficulty with the lateral flow compared to the galactomannan when the assays get saturated quite quickly. In terms of the median galactomannan indexes, again, we saw higher galactomannan index using the lateral flow assay compared to the galactomannan ELISA, potentially again demonstrating that this additional monoclonal antibody is increasing sort of the strength of signal. And again, we did have a higher positivity or higher galactomannan index in our control patients, but this again didn't go above the 0.5 threshold that we would potentially use. Certainly didn't go above sort of the threshold of 1, which would normally be used in BALs and MBLs. So in terms of the performance of the lateral flow, when we're testing these BAL, MBL specimens from the control patients versus the actual CAPA patients, and what we find is using the accepted threshold of 1, we pretty much have, according to the UDIM statistics, the best optimal, also the optimal performance for combined sensitivity and specificity. However, neither can really be used to confirm disease or to rule out disease. What we found was that if the galactomannan positivity threshold was increased to greater than 1.5, we then ended up with a specificity that was significantly greater than 90%, and the positive likelihood ratio was strong enough to basically say there was a high indication that these patients actually had CAPA. And basically, the stronger the signal, the more strength we have, the more confidence we have in this patient having CAPA. So what we wanted to do was, obviously, when we were testing these MBLs, BALs, they were going through some sample processing in that they were being heated with EDTA, then being centrifuged, and then being applied to the actual cassette itself, the lateral flow cassette. And this really takes it away from bedside testing. So we wanted to know, could we actually do direct sample processing when we took the MBL or BAL and added it directly to the cartridge, to the cassette? What we found is from the 10 patients where we actually did this, we had 100% sensitivity when we did manual inspection using the investigator's eye. However, when we did automated inspection using the cube reader, sensitivity was only 40%. But that was because basically the cube reader said that for 6 samples, there was no control line, although you could be seen by the naked eye, it couldn't be picked up by the cube reader. So overall sensitivity would have been 100%, with 6 of the samples being invalid. Unfortunately, when it came to our control patients, 10 BALs from these were also, basically off the 10 BALs that were tested, 7 generated a positive result. So the specificity was only 30%. Automated inspection improved it a little bit, saying that really there was only 4 false positive results, and the majority of the ones that we were picking up with the naked eye were actually below a galactomannan index of 0.5. Although, again, it was saying that 2 of the tests were invalid. So overall specificity is at best around 50%. So direct processing doesn't seem to add a lot, really, or certainly doesn't improve what we can do over what we would do when we were actually processing specimens. But I suppose we could say is that if we did have a valid run and the test is negative, it is potentially useful for ruling out CAPA. And what about performance in blood? Jean-Pierre has already touched on the fact that when we're looking at non-hematology patients, the disease might be slightly less invasive and we might get lower circulatory levels of galactomannan index. And that's probably the case with something like invasive aspergillosis associated with influenza, where we know we get tracheal and bronchitis, we potentially get less tissue invasion, and consequently we get less angio invasion and we get less galactomannan in the circulation. And we know that the performance of the galactomannan ELISA, when we test ICU patients with aspergillosis or we test flu patients with aspergillosis, the performance of the galactomannan ELISA when we test serum is less of that, less sufficient or significantly less than what we would get when we test BALs. So what we did is we tried to apply the IMI lateral flow assay to our CAPA patients using a galactomannan index of 0.5 to test serum specimens. We then compared this to some of the studies that were previously describing cases of CAPA and looking at the performance of basically serum galactomannan and serum beta-glucan, and what we found was that the serum galactomannan in cases of CAPA was very, very low, less than 20%, whereas beta-glucan was offering us somewhere in the region of a sensitivity of around 63%, 60%. So in particular, for our patients that were just from our study, we found that the serum lateral flow assay gave us a sensitivity of 28%, 5 out of 18 patients. Serum galactomannan analyzer picked up 1 in 5 patients. So a little bit less than the lateral flow assay. So again, potentially the additional monoclonal antibodies giving us a slightly enhanced sensitivity. Serum beta-glucan, again, we saw 67% sensitivity in our 18 CAPA patients. Okay, specificity for all 3 tests was 100%, but we do have to be careful with the serum galactomannan and the serum beta-glucan because these will have been used to define disease, so consequently you get an incorporation bias. However, the lateral flow assay here has played no role in defining the disease, and so it is quite a specific result. So to conclude, lateral flow tests provide rapid and quantitative results, particularly, or basically, if you use the cube reader, which in my opinion is essential to the performance of these tests. It's not particularly expensive and is easy to use, and even because it's battery operated, can be used in resource limited areas. It requires simple processes. Even sample preparation is very straightforward, and interpretation is very, very easy, even if you don't have the cube reader, but is improved if you have the cube reader. Testing costs are cheap at around £10 to £15, but I know that is a subjective point. But I would say that lateral flow assays are suited to diagnostic confirmation, where we're basically testing targeted specimens from suspected cases. Performance in blood isn't the best at this moment in time, and I don't really see it improving rapidly. So really, you're going to be testing BALs primarily for the diagnosis of CAPA. Specificity is proportional to galactomannan index. And the good thing is because of the simple process and the small size of the actual cube reader, it's easy to introduce these tests into containment level 3 facilities, which are critical when you're processing deep respiratory specimens. So for CAPA, the IMI Aspergillus lateral flow assay provides performance when testing BALs or MBLs that is comparable to the Bio-Rad galactomannan analyzer, but it's far more simple to actually perform and far more simple to interpret. The cube reader removes the subjectivity and provides a galactomannan index, which is key to determining the significance of a positive result. And a galactomannan index of greater than 1.5, certainly greater than 2, is associated with the presence of CAPA. Positivity in blood is highly specific and predictive of CAPA or invasive pulmonary aspergillosis in patients on the ICU that don't necessarily or haven't had a definition of CAPA confirmed. However, I do have to add the one caveat. Obviously, a lot of this data is on relatively small patient numbers, and we do require further testing from other centres to actually confirm the actual use and the utility and the validity of these tests. And on that point, I will stop. Thank you.
Thank you so much, Louis, for this awesome talk and great kind of like brand new data, in the making basically, or in the publishing. Very interesting data. So do we have time? I think we kind of like, moved on. Oliver, one quick question maybe, or should we just move on?
We do have a question for Louis, and that is from Spain. Are there any false positives in LFAs? False positives where you already expect it to be false positive, beta-lactamases or some certain foods or something, as we had with the early ELISAs?
I think given the assays detecting galactomannan, we're probably going to see the similar false positivity sources that we see with the galactomannan ELISA test. In our setting, we did have a couple of patients that didn't appear to have aspergillosis, and when we tested deep respiratory samples, they were strongly positive, and at the moment they are still classified as false positive. But overall, once you start getting above a galactomannan index of 1, 1.5, 2, false positivity is reduced.
Thank you very much. Stay with us because there might be more questions coming up. But anyway, all of the presenters are with us here until the very, very end. So Martin Hoenigl, I'm not going to introduce you because we had that already at the beginning of the whole the whole exercise, and Martin being the one who was so thoughtful to create this for us. So Martin will give a talk, a brief one, on point-of-care diagnostics from BAL fluid, other patient groups. I wonder whether there are any other patient groups, because in my hospital, everybody who enters the hospital is a corona case until proved wrong.
Thanks so much, Oliver. So yeah, the main reason for giving the talk is, as Luis emphasized towards the end of his talk, of course, the numbers we have currently for diagnosis of these tests in CAPA are limited. So we really kind of want to show a little bit more, how much data is existing, in patients before CAPA, and in large studies published before CAPA. And, to really emphasize on the value of these tests. And I'll move on. I have a second presentation right after and talk about the treatment of COVID-associated aspergillosis. So stay with me. I'm happy to answer questions after these two talks. I won't answer questions in the meantime because we're already advanced in time. So my disclosures, and Luis mostly introduced basically this test. This is the UK test, this lateral flow device test developed by Chris Thornton, which is around now for a number of years. Initially as a prototype test, and now also as a CE mark test. And there have been a number of studies on the prototype test, and what was found basically in one of our small studies where we compared the prototype UK lateral flow device with the CE marked final version of the lateral flow device, that really the CE marked version had equal sensitivity but slightly higher specificity. And this was kind of we retested samples with both assays basically and compared the results. But when really looking into all this kind of published evidence, and of course, it's harder to kind of compare those two because it's very different patient cohorts, different, settings, and different definitions sometimes of invasive aspergillosis. We find overall that the new CE marked Aspergillus specific lateral flow device test had an overall sensitivity of 64% and specificity of 87%. And I think what's important to emphasize here is, specifically, outside the hematologic malignancy setting, the performance seems to be a little bit less good, which comes back to the talk Paul gave, regarding the difficulties of defining invasive aspergillosis outside the hematologic malignancy setting, and the advances that are currently in progress. And soon, hopefully, this will be better. And I'll have a slide on this a little bit later on as well. When summarizing all the studies on the prototype LFT, we found a slightly higher sensitivity, 71%, and specificity of 92%. And what you can see here, and I think this is great, kind of just to keep in mind that, the numbers, of probable proven cases and putative cases here, is for both of these assay versions relatively high. We are well above 100 for sensitivity, and, for specificity, between 300 and over 600. So this is kind of more reliable data, of course, in terms of confidence intervals. We've also heard about the US test from Luis, about the lateral flow assay, which potentially is a more sensitive point of care test. You can see it here. It looks different, It's also, as Luis said, doesn't really allow for really kind of native sampling, at least according to manufacturer instructions, although it may be possible, as we've seen with Luis, to really do native BL samples. Results are usually read after 30 minutes and scores are given between 0 and 4. And the great thing about this test is also that it's, really expected to soon be FDA approved. And that will also, of course, open up, a big, much more institution being able to use this test. So what does the data say about the BL lateral flow assay for invasive aspergillosis? We have overall, over all these different studies, a sensitivity about 77%, the specificity about 81%. Although it has to be emphasized, and you can see it below here when breaking down the numbers, most of this data comes from patients with hematologic malignancies, and fewer published data so far in SOD recipients and ICU patients. Overall, when thinking about the sensitivity in those studies that compared it directly with BL galactomannan, it was pretty much, comparable between the LFA and galactomannan, but higher compared to, slightly higher compared to Aspergillus-specific lateral flow device and much higher than BL culture. That's where we're standing. there's also a relatively large study from, an Austrian-Brazilian study led by Hoenigl last Fleuel, where they looked into Aspergillus culture and microscopy positive samples and found a very high sensitivity and specificity of this lateral flow assay of both above 90%. Of note, this did not use clinical classification of cases. That's why it's not included here above in sensitivity and specificity, but really relied on a microbiological classification in terms of kind of like being Aspergillus culture and microscopy positive. I think the main reason, and that's kind of like something I want to quickly to emphasize here, is, the problems with the definitions, and that's why it may also explain the lower sensitivity outside hematologic malignancy setting, where we know that kind of like the different classifications here in blue, ARTC, and here kind of like blood, the other one, is really not overlapping too much currently. So we really need better classifications of invasive aspergillosis in these settings, which are currently in progress. Louis also talked about the new, process of automating the reading of the test results with the Cube reader. And I think this is a very, very important advancement that really allows this test to be standardized across settings. And that the potential benefit of using an automated reader was also shown in this study from Belgium, basically, from John Mercier in the Netherlands. It was a multi-center study with good amount of samples from hematologic malignancy patients and 75 patients with probable improvement in invasive aspergillosis. And what was found here, that really with the automated readout, the sensitivity improved further from 83% to 87%, and specificity from 87% to 92% versus a manual readout. And this can be specifically explained by the fact that especially these slightly positive test results are really hard to read with the naked eye. While, of course, once you measure the optical density indexes, this gets, much more accurately read. I'll also present some unpublished data, some data that are kind of like, currently in the process to be published, currently submitted, about the multi-center study looking in the BAL LFA for invasive aspergillosis. And, very quickly what we found here is, first of all, that, the BAL fluid LFA results correlated relatively well with BAL fluid galactomyn levels over all these patients. So it was 88 patients with probable putative IPA and 161 without IPA. And after exclusion of galactomyn as mycological criterion, which really, removed the bias of galactomyn performing better because it defines disease, we really found that diagnostic performance of the LFA was highly similar to galactomyn testing, with errors under the curve close to 0.9, both. What we also found is basically, that the error under the curve was a little bit better for hematologic malignancy patients, 0.917, and a little bit less good, but still above 0.8 error under the curve for solid organ transplant and ICU patients. So, still a very useful test. And I think what's also very important with this Cube reader, it really allows kind of like to use this test and compare results across centers. You really found astonishingly similar errors on the curve in San Diego, in Graz, and also in Mannheim, really indicating that this is, of course, now a very objective, basically, test result. In terms of cutoff, this is also going kind of like in the same direction that Louis touched, basically, for the LFA assay, probably a 0.5 ODI cutoff may be too low because it's not very specific. But once you reach a 1.0 ODI cutoff, of course, sensitivity and specificity are kind of like both acceptable. And with, specificity further, of course, increasing if you increase the cutoff further, between 1.5 and 2.0. Very important, and that's kind of like something, my last two slides quickly about the diagnosis. It's not only, we've shown basically that the LFA and also the LFD assay, point of care assays, can be used to diagnose invasive aspergillosis on their own. But specifically in those receiving mold active prophylaxis, they may also be a very valuable additional tool to galactomyn and PCR for diagnosing big breakthrough invasive aspergillosis. This is because we know that all the tests and LFD, but also of course culture and also PCR from BL and blood samples specifically really have reduced sensitivity once they are used in patients receiving mold active antifungals. So really combining multiple biomarkers in those patients who already receive mold-active antifungals is the way to go. And also this point of care assets to play an important role as a combination partner. This is already summarizing very quickly, going over this, that basically we have two commercially available CE mark tests available, the LFA and the LFP tests, which may reliably diagnose invasive aspergillosis, including CAPA, from BL fluid, and basically, could also complement other existing diagnostics for diagnosing these infections, especially in patients receiving mold-active antifungals. And with that, because of the advanced time, I want to make a big jump to treatment, basically, before going back to the questions. Sorry, Oliver, you have a quick...
There is one question that strictly refers to the diagnostics. So,
yes.
And there is a concern of one of our colleagues who has, it has to do with the availability, accessibility, and affordability of LFDs in developing countries.
Mm-hmm.
And can you comment on whether there is some sort of program or so of one of the companies?
Yeah, so basically, I'm not involved with either of these companies. I can only tell you in things that I've been kind of like CC'd in, or kind of like things I've facilitated in the past. So I know that LFA has started, multiple collaborations, with some, countries, and is very willing to kind of like, help countries who can't afford kind of like the current price of the tests. That's kind of like something that's in progress. And then I'm aware of a specific one collaboration in Iran. So, it would definitely make sense to reach out to, IMI and also On Diagnostics. I also know that On Diagnostics, especially in China, they have kind of like, a couple of programs also in some African countries. So I'm sure there's much, much more ongoing from the companies that they can kind of like, better kind of like talk about. Of course, it's a single-use test, right? So it's also possible to buy them kind of like, for some, highly suspicious cases. But I'm sure there's something that can be negotiated with the companies in terms of price when, buying more of these tests.
So worth reaching out. That's good to know. Thank you very much. And with that, I introduce Martin Hoenigl on treatment.
Perfect. Okay, thanks so much. So I'll now quickly talk about treatment, and also want to emphasize kind of like the publication we had from the ECMM about this topic, about COVID-19 associated pulmonary aspergillosis. In an article that is a review, but goes beyond, especially also in terms of immunological mechanisms, involved like a lot of awesome immunologists that really had like, gave their great expertise, and it's great to have kind of like, Carol summarizing and some of this data and adding some new points there. But that's kind of like also where you can kind of like read some more about treatment, because I will kind of like a little bit rush over my slides now, given that the time has already advanced. So of course, we have lots of different options to treat aspergillosis, but when, I don't want to rush that fast, but when thinking about, outside the hematologic malignancy setting and looking into guidelines, there's really, I think, one clear first line treatment option when we believe guidelines, which really is voriconazole in ICU setting, for example. And this is also in really displayed in the data we have so far for COVID-associated aspergillosis that was shown by John Salmanton-Garcia before. We really see voriconazole is the drug used mostly so far in these cases. But I think, besides the advantages of voriconazole, and we know the substance now for a long period of time, there's potentially also a number of issues of using voriconazole in the ICU setting specifically. And that's, of course, the narrow therapeutic window and the requirement to use therapeutic drug monitoring to also prevent adverse events, but also, ensure that it's effective. Drug-drug interactions specifically, this is really the biggest topic in the ICU, which may really limit the use of voriconazole. It's metabolized, via multiple systems, CYP-BC19, but also important CYP-B3A4 and CYP-B2C9. And there is even a publication that looked into kind of like, the drugs that are most frequently associated with major drug-drug interaction in the ICU. And voriconazole ended up there right on top. And this is about all drugs, not only anti-infectives. And voriconazole was really kind of like, a among the most important, associated with major drug-drug interactions in the ICU. It may also show voriconazole interactions with experimental COVID-19 treatments, including, of course, hydroxychloroquine, which probably will soon not be used anymore so much, atazanavir, lopinavir, and ritonavir. And I think just to mention, but this may be less important and relevant, remdesivir is also a weak substrate of CYP3A4, but its metabolism is primarily mediated by hydrolase activity. So drug interaction may be possible for remdesivir, but it may be less likely. So what about alternatives? And when you're thinking about alternatives, we heard, and this is a map about Azole resistance, of course, that of course liposomal amphotericin B, ambisome is a very relevant alternative, but so is isavuconazole as an alternative for treatment if voriconazole can't be used. And with liposomal amphotericin B, of course, we know it's great and for sure drug of choice for Azole resistant aspergillosis, which is, this has been described for COVID-19. But there's also an issue for ambisome, specifically in COVID-19, because we know that, in the ICU in general, but especially with COVID-19, renal insufficiency often complicates initiation of ambisome or requires discontinuation of this antifungal agent. And specifically, SARS-CoV-2 has shown renal tropism and been described as a frequent cause of kidney injury. So, if you want to start this, it's definitely, an alternative, but I think, you should, monitor renal function while using ambisome in COVID-19 patients. Isavuconazole is another kind of like alternative that can be used, that has some advantages above voriconazole in terms of kind of like having a more favorable pharmacokinetic profile and fewer toxicities. However, of course, it's still an azole, and it's also metabolized via CYP3A4 and could therefore be problematic. But it's still important to emphasize that compared to voriconazole, drug-drug interactions are generally less a problem with isavuconazole. Of course, we have other alternatives as well. Itraconazole, it's kind of like, it's fallen kind of like out of favor for many years now for treatment of invasive aspergillosis. It's a different story for chronic aspergillosis, of course, but CPA, for example. But I think the interesting thing about itraconazole is that there are some in vitro studies about this drug, about its antiviral activity, and specifically also as a cholesterol transport inhibitor, its antiviral activity against a feline coronavirus model. And this is now currently further developed to look specifically also on its antiviral activity against, the novel coronavirus. Also, we have a novel oral formulation, that has greater bioavailability compared to older formulations of itraconazole. It may be kind of like, a second-line alternative, not the first-line alternative, but a second-line alternative to think about if there's problems with other substances. But of course, again, it's an azole, and the drug-drug interactions pose a problem. And finally, the echinocandins, definitely very well tolerated, very few drug-drug interactions, definitely worth a thought, especially as a combination partner, because we know, of course, for monotherapy, we don't really trust the echinocandins so much, the currently available echinocandins for treating aspergillosis, but as combination partner, definitely a thought. And then, of course, and that's very important to emphasize, the future looks bright. We also have kind of like new drugs currently in phase 2B, phase 3 trials that I want to mention that may be used in the future to treat aspergillosis in the ICU, including COVID-associated aspergillosis. One is fosmanogepix, and the other one is olorofim. Fosmanogepix specifically has also currently a phase 2 trial that specifically also enrolls basically COVID-19 associated aspergillosis. So if you have a site or have access to a site, this may definitely be an option to enroll these patients. Also, olorofim, as similar kind of like the fosmanogepix, may have equal efficacy without the same burden of drug-drug interaction toxicity. It may therefore overcome the limitations of currently available antifungals in the future, but of course we also have to wait for them being approved and have to await kind of like, the phase 3 trial results for those. Finally, there's also 2 new echinocandins or echinocandin similar or like substances, namely resafungin and ibrexafungerp, that may be used in the future to treat, and especially I want to emphasize kind of like resafungin, which is a once-weekly echinocandin with improved activity against Aspergillus species compared to other echinocandins, and may kind of like play a role in the future for prophylaxis against CAPA, once this field moves along. And I think there's also already something in development that may kind of like come out soon or may not come out soon. We have to ask the company for that, but that's definitely something to keep in mind. And with that, I come to my conclusions. Overall, John emphasized that not all the COVID-19 patients with aspergillosis were treated, which is also to do, of course, that, some of these analyses, there are some retrospective analyses, not real-time analysis. So the data we have available as readers of these publications are not necessarily the same data that the clinicians had available in real time who were treating the patients. So overall, the evidence really indicates, and there's more evidence coming about increased survival, improved survival benefits if you treat early with antifungals. And voriconazole, of course, if possible, is the gold standard. But of course, be aware of drug-drug interactions, and liposomal amphotericin B and isovuconazole are the primary alternatives. And the future may look bright with phosphosphonated G, benzaldehyde, or FIM. But hopefully, at that point, we'll at some point also have a vaccine, although this may not, remove the new novel coronavirus, as a very relevant matter in our patients and as predisposing to CAPA. And with that, I want to finish and, thank you all for your attention and look forward to the questions.
Thank you very much, Martin. If I may, I would just like to briefly hint at the currently ongoing study with ibrexafungerp that we always were waiting for the oral echinocandin. Now we have an oral drug, but it's not an echinocandin, but a triterpenoid and nuclease. Anyway, the more important thing is that there is an open study running in multiple countries, and it's Aspergillus active, so it might be a good choice. If I can ask you one question, or it's not my question, but it comes from, I guess, from India. So given the prevalence of aspergillosis and the treatment choices that we have, you just went through them, wouldn't that be a scenario where one could, recommend antifungal prophylaxis or run a study on antifungal prophylaxis? The latter 5 words were for me now.
Yes, so I think it's a very good question, definitely. So I think what we're still kind of like lacking is kind of like evidence that kind of like the prevalence is the same in every setting. But at the same time, we know from Belgium that, some centers that found a high prevalence of aspergillosis already introduced basically, kind of like a prophylactic treatment, in this case with nebulized liposomal amphotericin B outside of a study, but just because, they saw aspergillosis is a big problem, COVID-associated aspergillosis, and they want to do something to prevent it. So overall, I think, definitely this is, something that's, warranted. So trials, that are looking into the benefits, of antifungal prophylaxis in terms of CAPA diagnosis, maybe even in terms of overall outcome, that's definitely something that's warranted and needed. And that's definitely something we have to talk about. The same with influenza-associated aspergillosis, where these trials are ongoing. So it's definitely something that's needed. And, we have a couple of, we can think about isovuconazole, we can think about voriconazole. We can also think about the new substance, ibrexafungerp, as you mentioned, but also, of course, resafungin, that may kind of like play a role here. So, definitely something that's needed and already planned, in some early phases, but that's something we're looking forward to.
Okay, thank you. Well, thank you very, very much. And I'd like to call our last speaker, Philipp Köhler, from the University Hospital of Cologne, where he, as you can see, the blue color of his shirt. So he's currently apparently working on the ICU, and he loves intensive care and soon will have a degree in intensive care. But in the meantime, he had to go through his board exams for hematology, oncology, and infectious diseases, and of course, internal medicine. So a lot, but that is what you need if you are really, really sick. You need Philip, and you need a CAPA management guidance. Go ahead, Philip. Thanks for being here.
Well, thank you very much for the kind introduction, Oliver, and thank you very much for the invitation and giving me the opportunity to talk about what Paul has already mentioned, a CAPA management guidance that we are currently discussing and drafting by that.
The sound is somewhat weak, so it could be the volume. Is there something you can do about it, or on the technical side? Yeah, please.
Is that better now? That is
super.
better. Sorry for that. Apologies. My conflicts of interest with a short break, you should have all see them. So I would like to give a short teaser trailer, and as of the short time amount that might have left, I'm quickly presenting it. We have formed a expert guidance and an expert panel that is looking into how to manage COVID-19 associated aspergillosis, and we are currently within the draft period of reviewing what has been gathered and drafted as information with a manuscript. And this expert panel, it covers a total of 6 continents. We have experts from 13 countries gathered around here, with US colleagues, with colleagues from South America, Africa, Russia, Australia, and of course of Europe. And it has taken some speed up in the later days, as we have managed to get endorsed by the various bunch of highly renowned medical societies, of course, the Ecmm and Ecmm fungal infection study groups and study groups of the critical ill patients. Ecmm, for example, will join us here, and many, many more. The list goes on, and we are currently working on getting endorsed by many more societies. So I hope that the list will enlarge a little bit during this process. And as I said, I can just briefly give you a teaser trailer on how it's going to be looking like, because I cannot show the final figures and the final draft of diagnostic and management pathways that we are going to discuss about, because it is matter of discussion right now within the expert group. But let me briefly show you what I have drawn when we were drafting the initial manuscript and the initial figures about how approaching those patients. And we are going to look at, and Paul excellently put it out, we are going to look at patients who have diagnosed COVID-19 by SARS-CoV-2 PCR, for example, and those patients have to be situated as the ICU ward, and they have to have IDS so that we have some mixture of risk factors and definite diagnosis. And of course, we are looking into proven CAPA patients where we have the best and gold standard of diagnosis being in place, having histology from biopsy, which will be, I think, a rare situation in those patients, having the pathologist showing us that there is invasive growth of the fungus within tissue, or that we have culture from sterile material being positive for Aspergillus species. And then we have, on the other hand, what we were discussing about to be probable CAPA, and we have discussed it with the disease definitions that we are trying to set, that we need to have a combination of microbiology, imaging, and clinical factors that all put us into the position to discuss about the patient having probable CAPA. And of course, we would all love to see that all the patients have the material for the epidemiology coming from BAL. However, we still need to define on how many puzzle parts are going to fit in the microbiology section. If we add PCR, if we add lateral flow device. So this is a matter of, I think, what's going to be a vivid discussion. And if at some point we include imaging, because it is rather unspecific in those patients, especially in RDS patients on the intensive care unit. And we have managed to see different treatment strategies, as Martin has put out and shown you and led you through in the previous talks. And what we are going to define is if we have, of course, a isolate that shows susceptibility to azoles, and then we will differentiate between first-line voriconazole or isovuconazole. But if, and this is again a repetition, if the situation remains the same in the final consensus statement, we will see how the draft will be accepted by the expert panel. And if we move isovuconazole a little bit more down, or if we are going to use it more maybe in intensive care unit patients right now. So second line could be, for example, liposomal amphotericin B or the other substances. And of course, as I showed, azole sensitive or susceptible isolates, I of course need to focus on azole resistant species and isolates, and there we could differentiate between a combination therapy. For example, if you are in a hospital that has a high yield of azole resistance, and you might have a situation where you suspect your patient of having azole resistance, COVID-19 associated aspergillosis. However, of course, if you prove resistance by cultural and susceptibility testing, liposomal amphotericin B will be in place, of course. So this is, and I'm coming to an end right now because of the limited time, and of course, as I put out this being a teaser trailer, and I hope that you are tuning in to the final publication, which we are going to push forwards as fast as we can. I would like to summarize, and I think the faculty of this great initiative could go align with those summarizing key points, is that we think that proof of Aspergillus species in lower respiratory samples from critically ill COVID-19 patients is to be considered relevant, and you need further diagnostics on that. And patients who are critically ill, they should receive antifungal therapy, of course, if you have your specimen collected by bronchoalveolar lavage, which may not be feasible in all your patients, either because of a higher yield of contamination and risk for healthcare workers during that procedure of BAL, or in another a case that your patient is too unstable to perform BAL because due to the severe RDAs of the patient during COVID-19. And we hope that we can give structured algorithms that may help clinicians to follow recommended diagnosis and treatment strategies. And with this, I would like again to thank all the great effort that all those experts have put into developing this consensus statement, which we will hope to see, and of course to the scientific societies who made a great effort in pushing this forward and giving us endorsement and support throughout this process.
Thanks so much, Philip, for the excellent talk. Also for making it just in time to kind of like, let me finish this within 2 hours. But before we finish this webinar, I want to ask one question. And this is about kind of like CAPA, whether this does only exist, and this is kind of like going out of your definition basically, in COVID patients with ARDS, or whether there is also reports in severe non-ICU and non-ventilated patients of CAPA. I think this is kind of like an important question that we continue to discuss. So what are your thoughts about this, and what do you know about this?
Well, for a Cologne view, we have not seen a patient out of the intensive care unit developing COVID-19 associated aspergillosis. However, of course, we could hypothesize about a patient who had severe RDS due to COVID-19 and has been cured from RDS and managed to get to the normal ward. And then we have a phase where the patient develops aspergillosis after 30 to 40 days of being into the hospital. So I can't really exclude those patients from our thoughts. However, I think that the main immunological factors that we discussed about, and the fact that the immunocompromised patients, I think, are mostly located at the intensive care unit, makes it more probable to find those cases at the ICU. However, of course, we have to be aware and focus that this disease also may take place in later stages of COVID-19, for example, at the normal wards. Yes.
I fully agree. I think the immunological mechanisms for invasive disease, specifically, and, really kind of like ARDS is playing a major role here. But, thinking about more chronic disease, and kind of like, patients we're seeing with kind of like long-term kind of like, lung abnormalities and injuries after COVID, if this is the case and we learn more about this in some patients, we can think maybe about, other types or more chronic versions of hearing later too. So this is in progress, and we will have kind of like to observe and continue to observe. Great. Are there any other questions? Any questions from my co-chair?
Well, more a remark or a question to the audience, which will not be able to answer, I guess. And we had some points where we discussed other rare fungi together with CAPA, and you're absolutely welcome to enter them into Daniela's and John's Fungiscope registry, and so that we learn more about it. Okay, so I wonder whether there is another Fusarium or another whatever other rare one. Just wanted to use this opportunity to invite.
Thank you so much. Okay, and with that, I wanna kind of like say a big thanks, basically, of course, to the excellent speakers for joining us this afternoon or evening for most of us. And of course, also big thanks to the big audience from around the world who joined us at whatever time, during the workday, in the evening, at night, for this webinar. Thanks a lot. And of course, last but not least, thanks to the ECMM and Congress Care for organizing this. And, also thanks to our sponsor, Diagnostics, for making this possible. And with that, I wish you a great day, evening, or night. Thank you.
Thank you, Martin. Thanks.